I'm going to talk about blood transfusion today in MDS and CMML. I want this session to be as useful to the people who are attending as possible. So I'm going to talk for about 15, 20 minutes. And then at the end, I'm going to present some questions that have been asked to me already. I'm going to answer those questions, and then I'm going to give it to the floor to ask as many questions that they want to ask about transfusion. Now, I'm a transfusion nurse consultant. I am a hematology nurse by background. I do have some experience with transplantation, oncology. I have quite a lot of experience, but I've been in transfusion for about 10 years. So with MDS and CMML, what we're looking at is a group of conditions where there is myelodysplastic behavior in the bone marrow. So that's where the bone marrow is producing abnormal cells. And then we've got CMML, where we've got a condition that is causing an overproduction of a certain type of cell in the bone marrow. What happens with MDS, and you can see here, I've got a little picture of your bone marrow stem cells. So it starts with your hematopoietic stem cell, which is like the cell that begins all of the cells that are going to be produced by your bone marrow at the end. So you have this blood stem cell. The stem cell later on will become myeloid cells. It might become lymphoid cells. And then those cells will graduate, as I like to say, into other cells like red cells and platelets and white cells. And what happens in MDS, sometimes in that myeloid chain, or when those cells are supposed to graduate, that graduation doesn't happen the way that's expected, and those cells start to behave abnormally. And when they behave abnormally, what it means is that you don't get the end production that you expect. So you don't get the normal red cells or the normal platelets or the normal white cells, which is why you get the anemia, the low platelet counts, and you get the neutropenia or the low white cell counts. With CMML, which is your myeloproliferative neoplasm, or a condition that causes you to make lots of cells, you get an overproduction of your monocytes. What happens then is your bone marrow, which is the factory of all your cells, where all your cells are produced, gets a bit crowded. And because it's crowded, those normal cells can't be produced in the normal quantities that is expected. And that's why you also get your anemia, your low platelet counts, and your low white cell counts. So this is a picture that somebody showed me one day. And when they showed it to me, I was very, very terrified because there was lots and lots of circles and I didn't understand. But to keep it really, really simple, this is just a tree looking at what happens to your cells, or what's expected to happen to your cells as they start to get produced in the bone marrow. So it's similar to the picture that I just had in the previous slide. So this is what we call the original stem cell, or it's like the original DNA in your cell that is supposed to go on to produce all the rest of the cells that are going to be pushed out of your bone marrow eventually. That lineage splits into your lymphoid cells. So these are the cells that go off to make the lymphoid cells. So your T lymphocytes, your B lymphocytes. And these are the ones, and as you can see, this is the myeloid chain. The myeloid chain is responsible for a lot of the cells that are going to come out of your bone marrow, which is the reason why conditions like MDS can have quite significant impact in the way in which your bone marrow is supposed to produce cells at the end. So you can see here, you've got your what we call a progenitor cell, which is a cell that has got a plan to go on later to become your red cells, your platelets, or your erythrocytes. So your red cells are also referred to as erythrocytes, your megakaryocytes, which are also referred to as platelets, and your white cells as well. And when you start getting that abnormality or that dysplasia in the cells, when the cells are not produced properly, it then means that we don't get these nice cells that we want at the end. So we don't get those red cells and we don't get those platelets, or we get them in very, very low numbers. And also with CMML, what happens here, we get an overproduction of the monocytes. So we get lots and lots and lots of them being produced in the marrow. The marrow gets too full, and therefore there's no space for some of these other cells like the red cells and the platelets to be produced. So when we have low levels of red cells and low levels of platelets and low levels of white cells, we call it a cytopenia. A cytopenia means you have a low level of cells. You might hear people use words like anemia, which is what we call erythrocytopenia, which is a low level of red cells. You may hear people say things like thrombocytopenia, which means you have a low level of platelets. You may hear people say you have neutropenia, which refers to a low level of neutrophils, which are the white cells that are responsible for managing infection. So when we want to treat the cytopenias, we have to look at a few different things. We have to look at managing the risks associated with those cytopenia, and that's our biggest concern. So when patients are coming in with anemia, we're looking at the risks that are associated with anemia. When they're coming in with thrombocytopenia or low platelet counts, we're concerned about the risk that is associated with that low platelet count. We obviously want to try and alleviate symptoms where we can. Those symptoms in anemia could be things like dizziness, palpitations, shortness of breath, tiredness. But also with platelets, there are symptoms associated with low platelet counts. That can be things like bruising, low level bleeding. So for people who had experienced platelet counts or low platelet counts, sorry, or seen people with low platelet counts, it can be things like bleeding. So when you're brushing teeth, bleeding from the nose and things like that. And we want to try and alleviate those symptoms. And also, we want to try and support the quality of life and the functional status of our people who are suffering from the cytopenias. So how do we treat cytopenia? Or how do we treat mainly anemia and thrombocytopenia? I will talk a little bit about neutropenia as well, but our focus in transfusion is going to be around a transfusion. So we're looking at blood transfusion here. Now, the first thing I like to talk to people about, because not everybody always knows this or really thinks about it, is that we don't actually give people blood transfusions. We give them component transfusions. But everyone says, I'm having a blood transfusion. But actually, you never have a blood transfusion. You have a component transfusion. So what happens is a donor, so that could be someone like me as a blood donor, I go off to NHS Blood and Transplant, the donation centre, and I donate a unit of blood. So it's about 500 mils. And what happens is NHS Blood and Transplant, who are the people that provide all the blood in transfusion, they come along and they take that unit of blood that I've donated and they split that unit into the different components. So that includes red cells. So from one donation from somebody like myself, you'll get 1 unit of red cells. You get 1/4 of a bag of platelets. So you need 4 people to produce one of these bags of platelets. So if you're having a platelet transfusion and you're having a pool of platelets, it's a donation from 4 different people. And we also get some plasma products from that as well, which we're not going to talk about today. There are other things and other ways to treat cytopenia, and there are other things that we do use as well. These will be condition dependent and what is suitable for you at the time at which you require treatment. Some of you may be aware of these medications or drugs or proteins that are used, including G-CSF, which we sometimes use in infection to stimulate white cell production. Something called eltrombopag or TPO, which is a TPO, which is your thrombocytopenia or your platelet stimulating agent, which causes your platelets to be pushed out of your bone marrow. And also EPO, which again is the same thing. It's a hormone that stimulates your kidneys to produce erythropoietin, which causes your bone marrow to produce red cells. Now, some of these things are not going to be suitable for you, or some of them will be. So sometimes blood transfusion is the better choice for you. In other cases, it might be that they want to introduce the use of these stimulating agents. And that will be a clinical decision based on what's going on with your case at the moment. So what I often get asked a lot of questions about is when do we transfuse patients and when do we consider transfusion? Now, sometimes you'll hear people refer to things like the trigger and the threshold. You may hear words like your HB, your platelet count. You might hear people talk about your neutrophil count. And these are the things that we are looking at when we want to transfuse our patients. And we want to know what is safe, what is going to impact you in the best way. We also are concerned about those symptoms of cytopenia, which I mentioned in the beginning, and we want to talk about how you are affected. So what I can say is that we also have to consider something that isn't often spoken about a lot, and people don't always understand what's going on in the background when we're looking at blood transfusion and also the use of stimulating agents. We need to think about the resource constraints, what is available and what is sustainable as well. And that's sustainability for transfusion, but also what is sustainable for you. So blood results is going to be the main reason or the main thing that we look at when we transfuse patients. So for a lot of people who have gone into outpatient settings to have their transfusions, what normally happens is you go into a phlebotomy department and you have a blood test. Nobody sees you except for the phlebotomist. They take a count from you and they will get your full blood count, which will have your hemoglobin and will have your platelet count. At this point, nobody's actually seen you. And that's why I say that the main instigator of transfusion is actually a result. So someone will look at your blood result. So whether they'll look at your hemoglobin or they'll look at your platelet count. Now, I've put 2 results here. I've put a hemoglobin and I've put a platelet count here. I'm not saying that these are the standard hemoglobin or platelet count. But what I will say to you is normally when the counts start to drop below these numbers is when we start to think about transfusion. And when I say think, there are many things that we're taking into consideration at this point. The reason why I say when we're looking below these numbers is normally a HB of 100 will not precipitate transfusion unless you are bleeding or there is something else going on with you or you have symptoms that you've discussed with your clinician. But normally, majority of the evidence that's out there in transfusion will say that once the HB is above 100, and this is for patients who are chronically transfused. So when I say chronically transfused, these are patients who are living with transfusion every day. They're requiring transfusion to survive. So I'm not talking about bleeding patients. I'm not talking about patients who have had anemia because of iron deficiency. These are patients who have bone marrow failure. These are patients who perhaps have cardiac failure and are requiring transfusion management to be able to have a good functional status. So normally we would say, as long as the HB is above 100, your patient is unlikely to require a transfusion. There may be exceptions to that rule, but that is what will happen in most cases. And that's the same with platelet count. Once the platelet count is above 50, normally there is no indication for you to transfuse a patient, except for a very, very small few number of risk factors, which we can discuss. But normally that will be in an inpatient setting. But as an outpatient, it's highly unlikely that you will require transfusions if your counts are above these numbers, unless something else has happened. When we look at these numbers, we then want to think about the reason for the transfusion. We want to think about the individual patient, what is happening with that patient at the time, and we want to consider the risk versus the benefit of that transfusion, because transfusion is fantastic. And I stand by that as somebody who gives out thousands of transfusions a year, but there is obviously risk associated with transfusion, risk for the use of the blood component itself, but also risk associated to the patient and the patient's condition. So I'm going to start with the one that's slightly easier. So I'm going to start with platelets. Now, when we, in a couple of slides previously, I talked about the trigger and the target. Now, as a person who deals with patient blood management, which is your treatment of patients requiring transfusions, but also the management of patients who don't have transfusions, we talk about a lot about the trigger and the target. The trigger is the point when you need to introduce a transfusion, or the point when you want to introduce a transfusion. And normally the trigger is a number or a scenario that is going to require you to need a transfusion. Now, the target is variable. So some people will say, my target hemoglobin should be this. What I normally say is that the target doesn't need to be a number. Sometimes it can be the alleviation of symptom. It can be the point when there is no more benefit from transfusion. So it can be a few different things. And that's similar with platelets as well. So initially I talked about this platelet number of 50. So normally with a platelet number of 50, you can have most surgical procedures quite safely, but again, that will vary. And you can see from my little blue box that I've put here about the different platelet thresholds that are used. But normally with platelets, what we say is that if you have a patient who is asymptomatic, so there's no bleeding, and they're not going for a surgical procedure, that a patient can be quite safe as long as their platelet count is around 10. And I say around 10 because your platelet count is only as good as the moment that you've had it taken. And if you take it again and you take it repeatedly through the day, your platelet count will go up and down. So there's lots and lots and lots of evidence out there that supports good platelet thresholds for patients. So normally they say a platelet count around 10. However, there's been a lot of studies in patients who have what we call chronic bone marrow failure. So patients with MDS, patients with aplastic anemia, patients who are not having active treatment, so they're just being transfused, which actually says if there's no bleeding, we shouldn't give any platelets at all. Now, people are a bit funny about that because nobody likes to do nothing. So often we do like to say, as long as your platelet count is around 10, you're okay. And if your platelet count falls below 10, we will give you a platelet transfusion. This is very much prophylactic. Now, when we talk about transfusions, we talk about treatment transfusions and we talk about prophylaxis. Prophylaxis is the use of transfusions when we are trying to potentially avert risk of something that hasn't happened. So your platelet count is less than 10. There hasn't been any bleeding. Nothing's happened. We give you a prophylactic platelet transfusion. We are not treating anything except for a number. So we know your platelet count is less than 10, and we're just going to give you a pool of platelets just to be safe. There is very little evidence that says that giving you a pool of platelets is going to stop a bleeding event occurring. There's very little evidence to say that those prophylactic platelet transfusions can be useful, but we do them because we want to try and reduce the risks that if something were to happen to you, for example, you were out and you fell over and hit your head, by having a pool of platelets, it means that that risk, if something was to happen to you, would be significantly reduced. Hopefully that makes sense, but we can touch on that in the questions. Okay. When you start to have what we call additional risk factors, so for example, if you come into hospital because you're unwell or you have an infection, We then start to operate slightly higher platelet counts because we're concerned about the risks that are associated with bleeding due to these additional risk factors. So, for example, if you have infection where you have rapid cell turnover, we try to aim for a platelet count around 20 because we know that because there is infection, you may destroy those platelets a bit quicker. So that's our platelet prophylaxis. So that's where we're treating things that haven't happened. Then we get to the point where we start to look at platelets in treatment. So something's happening to you. So for example, there is some bleeding, and we start to look at the grade of that bleeding and the volume of that bleeding and the concerns that are associated with that bleeding. So for example, if you're going for a surgical procedure where there's definitely going to be some bleeding because we're going to open or cut, then we're going to look for a slightly higher platelet count because we want to make sure you've got some platelets to help to stimulate your coagulation cascade or the cascade that helps you to make clots. And platelets is important in that process. So if you're going for surgical procedures, we will introduce platelet transfusions at that point. Depending on what that procedure is, we will decide how much platelets we need to give you. So if you're going for, like, say, a line insertion, a Hickman line, so the lines they put in your chest, we might want a platelet count between 30 to 50, depending on the surgical technique that's being carried out at the time. And that will normally be decided with guidance and the clinicians that are carrying out the procedures. If you're going for a surgical procedure like a knee operation, they might want a platelet count around 50. And most of the evidence supports that you can safely carry out those procedures with those platelet counts. We also give platelets in the procedure if there is bleeding, if we're worried that the platelet count is falling during the bleeding. There are some cases where we might need to operate even higher platelet counts, and most of this is not because we think that a higher platelet count will make a difference. It's actually because there's very little evidence in those areas. So sometimes we say, let's make a slightly higher platelet count. For example, if somebody's had a bleed inside their head, we know that a very, very small bleed in such a small space can cause lots of harm. So we operate slightly higher platelet counts, but this isn't very well evidence-based. And actually what we find is it can be quite difficult to maintain those platelet counts, especially if we've been giving people lots and lots of platelet transfusions in the past. And that's platelets because it's very, very extensive. So most of the time, if you're an outpatient and you're coming in for outpatient transfusions with MDS or with CMML and you have a low platelet count, you may work within you may be having treatment within an organization that's either using the chronic bone marrow failure targets, which is if there's no bleeding, we give no platelets, and that will normally be restricted to patients who are having no other treatment except for transfusion, or they'll be offering you platelets if your platelet count is less than 10. If there are additional risk factors, that platelet threshold will change, but that should be associated with additional risk factors. For red cells, it's a bit more complicated. So there is evidence out there around a red cell transfusion and what is an appropriate red cell transfusion threshold. The trigger being the point that we want to introduce transfusion. Now, what I would say is that most of the evidence says that definitely around 70, we need to introduce a transfusion. And that's not just for MDS, that's for most patients. So for most patients, once the HB is 70 or less, we are going to look to introduce a transfusion, especially if you're in a situation where you cannot recover your bone marrow function by yourself. So if you're not suddenly going to start producing a lot of red cells, we want to introduce a transfusion for you if your HB is less than 70. Now, if you look in this orange box that I've populated here, you'll notice that these numbers come from what we call the National Blood Transfusion Committee. So that's the committee that produces the guidance for national transfusion thresholds for this country. So the group here, or the number here, that MDS and CMML patients or patients with myeloid dysplasias or patients with myeloproliferative neoplasms would fall into is this R3 category, which is where you've got, or R4 as well. So R3 and R4. So R3 is where you've got stable patients and they've got cardiac syndromes, or you've got patients who are chronically transfusion dependent. So that means that they're having consistent transfusion. And what we're saying is that at the point where the HB is 80, we are going to introduce transfusion. So here we are looking at numbers only. So if you go into that phlebotomy department, like I mentioned before, and somebody takes a count for you, we're going to be looking at a HB around 80, and that's where we would probably want to introduce a transfusion. However, there will be times when that number might be higher and we need to introduce transfusions, and I'm going to talk a little bit about that in a couple of slides. The target in transfusion is often alleviation of symptom. You have a patient who is dizzy, we give you a transfusion, we'll give you a single unit. If that improves your symptoms, we might not need to do any more. It may be irrelevant what the post-hemoglobin count is after your transfusion because the symptom that you presented with has gone away. So that's what we are looking at when I'm talking about the target. So what is the target for that patient? Again, with when to transfuse, what does the evidence say? Because evidence is very, very important in nursing, in medicine. We always talk about evidence-based practice. Now, in terms of evidence in patients with chronic bone marrow failure in transfusion, there is some evidence out there, but what I can say is that the research isn't great. A lot of it sort of like we've done a lot of research, and what we've decided is we need to do more research because there's lots of confounding factors as to what causes patients to feel the symptoms that they feel. What causes patients to feel that they've had improvements after transfusion. And sometimes it's very difficult to say, this number is fantastic, this number works for everybody, this is what we should do. And also different patients present in different ways. So some of you may know other people who've had MDS or CMML, and you'll know that some patients require a transfusion once every couple of weeks. Some patients are requiring transfusions once every couple of days. Some patients are having platelets and they're responding fantastically. Some patients have platelets and they don't respond at all. There's lots of different things that are happening there. Most of the studies around thresholds of transfusion are carried out on inpatients. So we have inpatients, and inpatients are managed completely differently. They're sitting in their hospital beds being cared for. They can probably have quite restrictive transfusion thresholds quite safely, and there's lots of evidence to support that. But there's not so much evidence around what we're doing for the people who are walking around in the streets, living daily with anemia. And that's simply because anemia affects people differently. Some patients can tolerate quite low hemoglobin levels and be quite fine without requiring higher transfusion thresholds. Some patients, once their HB start to dip just below 100, it just is too much for them to cope with. And that's why we have to also look at the risk versus the benefits, but also an individualized approach to transfusion for patients. There's also no one correct answer. It can be largely generalizable to the advice to try to reduce the risk that's associated with the cytopenia. So obviously we want to transfuse you to reduce the risk related to, let's say, a low platelet count. We want to give you platelets so you don't bleed. And also with anemia, we want to give you enough red cells so that you are not breathless, you're not dizzy, you're not having those severe symptoms associated with anemia, but it might be impossible to transfuse you all the way up to the point where you feel completely normal. So what are the benefits of transfusion? Symptomatic control, a better quality of life. And I think most patients, especially outpatients, this is going to be the main thing for you. So lots of patients look at numbers, but I always say to patients that actually you should look less at the number and more about how you feel. So we've given you a unit of blood. Does it make you feel better? Do you feel like a single unit has been enough for you? Do you feel like you need to have two? Obviously, there are some situations where that may not be an option, that may not be a choice. It might be that someone's looked at your count and decided that actually, because your count is so high after a transfusion, a second unit won't be in your benefit, and they have to consider the risks that are associated with transfusion. We're obviously wanting to reduce those risks associated with the lower counts. So that's one of the benefits of transfusion. We might give you some platelets and it may stop bleeding, it may not. When we're making those decisions to give you transfusions, we have to also consider the risks that are associated with transfusion. Now, as a transfusionist, I always have to talk about transfusion reactions because they are a risk that is associated with transfusions, and we would manage those on an individual case-by-case basis, making sure that we consent patients appropriately for transfusion. And patients should have full information about the benefits and the risks of transfusion, including the risks of reaction and what we would do in those particular cases, so that patients would know what to expect. In the use of red cells, there's also one of the biggest issues that we have, especially in patients who are chronically transfused, is the risk of iron overload. And the reason why we have that risk of iron overload is because when we transfuse you with red cells and those red cells are destroyed, what happens is that the iron from those red cells is held by the body, and the body then uses them to reproduce red cells. Now you can imagine if you have a disorder that means that your bone marrow isn't producing red cells, that iron doesn't get used up. So when we are giving you transfusions, you are keeping every single iron element that comes out of those red cells. So once those red cells die, that iron gets stored in your blood. And once the blood becomes saturated with iron, the iron starts to get pushed into your organs. So mainly into the liver, sometimes into the spleen, and also into the heart in some conditions like that. And that's why we're quite concerned about how we give transfusion and making sure that we're managing the transfusions that we're giving you appropriately. We can use iron chelation to try to reduce iron overload, but as you can imagine, iron chelation it's useful, but it's not as aggressive as the iron loading itself. So it can be very difficult to get a balance where you can remove all of the iron that you've left behind from transfusions just by iron chelation alone. And actually, iron chelation can be quite a serious side effect of transfusion. And when your ferritins are very, very high and iron is going into the heart, it can be a concern. Another concern that people don't talk so much about, which patients with MDS, some patients may experience, is a loss of response to transfusion. So what you might find is that we start giving you a couple of platelet transfusions a week, and then suddenly you need a few more. And then some patients need them every few days. And then you might come into hospital and realize that you're requiring platelet transfusions every single day. What you might notice is that your platelet count isn't quite going up the way that it was before. And platelet refractoriness is actually a very, very common side effect of repeated platelet transfusions. Also with red cell transfusion, what you might notice is that you have a single unit of blood, you feel fantastic. Then you need 2 units a week. You don't feel as great as you did when you had 2 units last time. So we give you 3. And actually you start to find that even though the hemoglobin is going up, you don't feel that symptomatic relief that you felt before. Some of that can be disease progression. Some of that can also be that you are just losing the effect that you used to have on transfusion. And unfortunately, it's a phenomenon that's not always well understood, because we would expect that if you have the oxygen carrying capacity with a high hemoglobin, that you should feel that symptomatic relief, but sometimes patients just stop feeling that relief. So these are patient information leaflets about transfusion and anemia. They are for patients, written by patients, to try and help navigate through the consent information around transfusion, because all patients should be consented for transfusion and the risks and the benefits should be discussed, but also the alternatives that are available to you. There is not always exact like for like alternatives, but they should still be discussed with you. So one of the things I did mention before about transfusion is resource, and resource is an issue that isn't touched on a lot when we are talking to patients about transfusion. Now, for people who were being transfused in the last year, you may have been in your hospital when people may have mentioned the fact that we were in a national blood shortage. Now, I've been in transfusion for almost 17 years now. And in that 17 years period, in the first sort of 10 years, we didn't have any blood shortages. We always talked about the fact that there was not enough blood, but it was never enough that it actually changed anything in hospitals. We sort of talked about it, but we all went about continuing to do things the way that we did have always done them. Then during COVID, we saw our first long-standing blood shortage, which actually caused us to have to cancel surgical procedures. We had to cancel bone marrow transplants. We had to cancel different treatment methods and restrict transfusion use because we just didn't have enough blood donations. Some of it was related to COVID, but what we've also seen is actually as our population is getting older, we're seeing more and more people coming with communicable diseases, so things like oncology diseases, cardiac disease as well, patients requiring more and more transfusion. We're doing a lot more transplant, a lot more chemotherapeutic regimes which require transfusion. We're also seeing a lot more trauma, which means that our blood stock and our blood usage is increasing, but our donor population isn't. And that's a really, really big problem in transfusion at the moment. So even though we have a lot of patients that come forward and say, actually, I really need more blood, sometimes we just don't have the blood supplies. And it's not quite like drugs where we can look to other suppliers or look to other people to produce the blood. It's just really dependent on donation. And that's why we always say to patients, please look to your relatives if you're not able to be blood donors yourselves, if your conditions don't allow for it. But do ask your relatives where possible to come and donate blood. Because for every single blood donation, as I mentioned before, you can actually give up to 3 transfusions to somebody. So that would be a unit of red cells, and that would be 1/4 of a pool of platelets as well, and plasma products too. And I'm sure you can imagine if you're an MDS patient and you require 3 transfusions a week, that means that you'll require 3 people to donate blood to ensure that you're able to have those transfusions. If you're requiring 2 units in every sitting, you'll need 2 different people to be able to do that donation. And each blood donor can only donate blood 3 or 4 times a year. So actually there is a very big issue at the moment with demand versus supply. And in all of the talks and the conferences that we go to in transfusion at the moment, there is a lot of discussions around transfusion stewardship, which is where we're looking at being as restrictive as is safely possible for patients and looking at how we can manage blood stocks appropriately, which sometimes doesn't always translate very well in the clinical area when some patients are saying, please give me 2 pools of platelets, please give me 2 units of red cells because I will feel better. And we're concerned that actually we don't quite have the blood supplies to be able to offer that kind of service. And that is something that sometimes does need to be considered in local hospitals. By no means am I saying, any one condition is more important than the other in terms of transfusion, but transfusion stewardship and the use, the appropriate use and the sustainability of resources is becoming a bigger and bigger concern for us. So I finished talking now, and I'm just going to go to the question section. Now, these are some of the questions that were sent to me before, and I'm going to try and run through them, and then I'm going to open the floor to questions from the people here. So the first question was, what is the correct transfusion trigger or threshold for MDS? So as I mentioned before, the guidance out there says that we would normally introduce a transfusion to a chronically transfused patient, and MDS and CMML patients who have moved to transfusion would be classed as the chronically transfused. Now, what I would normally say is that there is enough safe guidance out there to say that if your HB is 80 or less, you can have a blood transfusion. Because you are classed as the chronically transfused, unless there is a clinical indication as to why transfusion is not in your best interest, there is enough guidance to say that you should be able to get a blood transfusion. How many units of blood that you get and when and the frequency of that transfusion, that will all depend on your clinician's decision, looking at you as an individual and how that translates to your symptoms and how that improves things for you. What I do recommend in terms of patient advocacy and to ensure that you're having a better system in place is that this is discussed well in clinics and that you document it in your notes so that when you're going to your outpatient settings, they know what your triggers and your thresholds are and the targets that are set for you. And it means that you don't have to have that conversation every single time that you come in. So if your clinician documents, we are trying to aim for a target hemoglobin of this, or we are trying to transfuse you when your hemoglobin gets to this level, and we would like you to have 1-2 units of blood, and that is documented in your notes, it takes away some of the ambiguity in outpatient departments. As you can imagine, in the outpatient department, there are lots of different patients. When I used to work in outpatients, in my transfusion days, I would be transfusing MDS patients next to sickle patients, next to thalassemia patients. They all have got different hemoglobin targets. So it is better that that is discussed and documented well in your notes so that your the nursing staff that are looking after you in the outpatient settings know how to manage your care. Does sex, body mass make a difference to the decision to transfuse? So the answer to that is no, and I'll tell you why. We should be looking at patients as individual. Once upon a time, our biggest concern about the differences in hemoglobins in our populations was weight, height, and things like that. But I'm sure you can imagine now you have small people and you have big people and they overlap. So actually body mass and sex makes very little difference, especially in the time when we're transfusing patients who are slightly older. As long as there is an active menorrhagia. So if you have got patients with MDS who are younger, who are still having periods, you might find that, yes, they are impacted simply because they are still having periods. But if you're not having periods anymore, you're pretty much looking at hemoglobin and how that hemoglobin affects you as an individual. So when your clinician is making a decision, they shouldn't say, well, you're a man, we're going to transfuse you a little bit more. It should be based on what is good for you. Does the frequency of transfusion indicate the progression of disease? Now, this is a difficult one to answer. For some patients, it might be. For other patients, it may be that this is just where your disease started. Also, that loss of response, which I was talking about, that can happen to patients irrelative of disease. So especially in platelet refractoriness, where patients have platelet transfusions, some patients will lose response to platelet transfusions very quickly. They have what we call the immunological causes of refractoriness. So the platelets are slightly a bit of a mismatch to the recipient. and your body will just light those platelets up and destroy them. It has got nothing to do with disease. It's an immune response that your body does to protect you. Unfortunately, it's protecting you from something that you need. So it doesn't always mean that it's progressive disease, but sometimes it can. So it really does depend. And what I would recommend is that if you notice that there are changes in your transfusion requirements, that when you go for your consultations, that you discuss it with the clinicians who are caring for you and you ask questions as to why that is. Does blood pressure naturally lower with the volume of blood in circulation is lower due to a transfusion being required imminently? If so, does this add to symptoms of fatigue? And should the transfusion therefore take place imminently? There's lots of questions in there. Does blood pressure naturally lower when the volume of blood in circulation is lower? If it's significantly lower, then yes, it will. So you can imagine blood pressure is caused by the amount of pressure that is in your blood vessels. If there is less in there because you have a lower hemoglobin, then your blood pressure will drop. However, when you think about where you are keeping your hemoglobin, so let's say you're being transfused all the time and your hemoglobin is sort of sitting around 80 to 90 or 90 to 100 and your HB comes down to about 90, it actually isn't coming down very far. It's come down very far from where normal hemoglobin is. So if your normal hemoglobin a long time ago or right at the start of your treatment was sort of like 150 and it's come all the way down, you might notice that you have a significant drop in blood pressure at that point, but you sort of stabilize out. So actually that change in hemoglobin between where you have a transfusion and where you're fine is actually very small. So you'll probably notice that it has very little change in what your overall blood pressure is going to be. However, some patients will become very anemic. So it might be that you have a transfusion on a Thursday, don't come back into hospital until the week after, and you have a significant drop in your hemoglobin, which causes your blood pressure to drop. So there is definitely some association between blood pressure and hemoglobin, especially if the hemoglobin has fallen very far. Do you need to have a transfusion imminently? If you are feeling symptomatic of anemia and it's impacting your blood pressure to the point that you are feeling dizzy or you are feeling dizzy when you're getting up and sitting down, then you probably need to have a blood transfusion pretty soon. Does it mean you need to walk into A&E? Probably not. If you are feeling very symptomatic to the point that you are feeling ill, then yes. But if you're noticing you're feeling just a little bit dizzy when you're sort of moving very quickly, and you know that you can go to your outpatient's appointment in the next sort of 48 hours, you probably can wait 48 hours. But as I will definitely mention, if you feel unwell or you are concerned about your symptoms, then by all means, you should seek medical help. Does it add to the symptoms of fatigue? Yes. So low blood pressure will add to the symptoms of fatigue. Anemia will also add to the symptoms of fatigue. You can imagine anemia is associated with your body's ability to perfuse itself, as we would say, so to carry oxygen around to your tissue. So if that ability is reduced, you will definitely feel tired. It's a little bit like when you're running a race. As you start to get to the end of that race, when you've run for a long time, those red cells have worked very hard. When you start to breathe very quickly, they're not perfusing those red cells as well. So towards the end of the race, you start to get a lot more tired and you need a break to recharge yourself, to recharge your red cells. And it's like in transfusion, we give you a transfusion, those red cells are charged, you are going to be able to perfuse them, there's going to be more of them to carry that oxygen around your body, and therefore you will feel better. Hopefully. So it's obviously, as I said before, some patients will lose that response. Question 5, as we all have different natural levels of hemoglobin and men's levels are usually higher than women's, why are arbitrary thresholds of transfusion imposed? So this is one that I took a long time to think about how to answer this question because I wanted to answer it correctly. Now, there is normal hemoglobin, and normal hemoglobin is for people who do not have MDS. There is the normal hemoglobin. And then there is the hemoglobin that is normal for people who are being transfused. Now, what we find is that these figures that we talk about when we say we're imposing these figures on people, remember, as I said, there is a number where we definitely need to introduce a transfusion because we're concerned about the risks that are associated with anything lower than that. The reason why we put that level in there is because if that level drops off too low, you start to become at serious risk of things like organ damage because the HB is just too low. It's dangerous for you. You might be at risk of things like fainting, dizziness, where it's actually quite dangerous. So that's why we say that threshold of 80 is where we want to definitely start looking at introducing transfusions. Some hospitals will be more restrictive and say 70. I say, clinically from transfusion, that is something that you can challenge because you are chronically transfused. The guidance supports that at least with a HB of 80 is where we should start looking to introduce, or less than 80 is where we should start to look to introduce transfusion. That threshold can be changed if you become an inpatient because you are monitored on a daily basis. But when you're leaving and going home and going out into the community where you're expected to do things, we should be operating a slightly higher threshold for you. We are not looking at normal hemoglobins anymore when we are transfusing patients, and we cannot transfuse people up to normal hemoglobin. As I'm sure you can imagine, even in healthy people, normal hemoglobin is variable. There are people who live every day with hemoglobins of about 110, and that's what's normal for them. It doesn't cause them any problems. They don't have any symptoms. However, if you put that person's blood test into a machine, the machine will tell me this person is anemic. This person is absolutely fine. That hemoglobin works for them, and that's okay. So these figures are, no one's really bothered to ever rework them because they've been around for a very, very long period of time. They carry very little benefit in a clinical setting. And it's actually only when hemoglobins are dropping below 100, we start to concern ourselves as to what the reason for that is, especially if we can't see it in daily presentation. So for example, if patients are not actively bleeding in front of you, they don't have menorrhagia, we will then start to ask questions as to why that hemoglobin is falling. So we don't look at normal hemoglobins. We look at the hemoglobin that is suitable for you based on your condition at the time. And we look at figures because figures help to steer decision making. We don't always see you to be able to say, this hemoglobin is good for you. And actually, a hemoglobin of 100 may be okay today, 80 might be okay tomorrow. It might be different, and it all depends on disease and disease progression and also the symptoms for you and what is working for you. Question 6, how can we as patients and caregivers better advocate for transfusions at a more helpful frequency and level? So that goes back to what I was saying about ensuring that you have appropriate documentation as to how the decision making of transfusion should happen for you. So it could be that you find it very difficult when you're breathless. So it could be that that's what's documented in your notes. If Mr. Smith is experiencing significant breathlessness, we might want to consider transfusion if the hemoglobin is around this number. We should always pair symptom with a number. And the reason why I say that is because if Mr. Smith is breathless, but his hemoglobin is 120, I'm probably not going to transfuse him. I'm going to be saying that your hemoglobin is okay. And actually, the risk of that transfusion outweighs the benefit that you're going to get at this point. I don't want you to have that additional transfusion, which may cause you to have more iron, because actually I think there's going to be little clinical benefit. And that should be well documented in your notes. And you should have a good understanding of that. And your clinician should help to make sure that they navigate you through that process, so you know when people are trying to introduce transfusion, when that should be good for you, but also when there needs to be a decision around actually, is this transfusion going to be useful to you? Question 7, is there any UK research on the impact of freshness of a blood unit and the benefit to the recipient? I understand a US research study has shown that there is less oxygen available in the hemoglobin contained in donations near to the end of the expiry date. Now, this is a very hard one because there's been lots and lots of questions about blood and blood's expiry date. Now, a normal red cell has a shelf life of about 120 days. When we take those blood units into hospitals and we donate to patients, the longest unit of blood will normally have an expiry of about 35 days. Now, the reason why that expiry is halved is part of this reason, because what we want to say is that we want to give you the freshest blood that we can, even when it's coming to what looks like its expiry date. Okay. So what we're saying at that point is actually, even if we transfuse it on the last day, you're still going to get a very good effect out of that unit of blood. If you look at a unit of blood on the day 1 of collection and you look at it on day 35, there most definitely is going to be some difference. That unit is slightly older, definitely. Some of those red cells units are going to be older. Some of them will be quite fresh, but also you can imagine once you take blood out of the donor and you start to put it in the fridge and do all sorts of things with it to try and keep it safe, it's not behaving in the way in which it's normally supposed to behave. So it can be very difficult for that red cell or that platelet to stay as fantastic as it was for the day of collection. However, when we transfuse it into you, it then goes back into a normal environment. So then it starts to behave a lot better. And because now it's inside you and it's warm and it's being perfused, it actually works a lot better. In terms of oxygen carrying capacity in red cells, what I like to remind people of is that the unit of red cells does not become oxygenated in the bag. Remember, the way that a red cell works is that it goes around your body, it goes into your heart, and then gets pumped to your lungs, where the oxygen is placed inside the red cell unit through a gaseous exchange. So actually the oxygenation is carried out by you. It's not actually carried out just randomly in the bag by itself. There is a level of oxygenation that takes place there because the red cells do breathe, but the oxygenation is carried out by you. So it's your job to oxygenate those red cells and to keep them going around your body. Yes, we do find that as the unit gets older and older and older, so when we started looking at units 40 days, so this is after expiry where we would not transfuse them, so 40, 50 days down the line, red cells will start to die, but a lot of that is because of the way in which we're storing them. And as I said, once they're put into your body, they actually perform a bit differently. So yes, I know that there are studies out there that say that red cell units are, not as good as they are on day one. That is true, but they are still very good and they are still very, very useful. And actually, if I transfuse a unit of blood to you on the last day, you're probably going to get a good amount of response out of that unit, as you would do if you were going to get a unit that was bled on day one, which no one ever gets unit day one bleeds because they're still in the National Blood Service at that point. I'm saying that I wouldn't want you to get a unit of blood that's at its expiry every single day, because I would want you to obviously get some fresh units if you can. But again, as we talked about before, a lot of this is about donation and blood availability. It is, we can't, when we call up NHSBT and we ask for blood units, as somebody who orders blood, they send us what they send us. So they might send me something that's got 5 days left on it. Sometimes, especially with platelets, they may send me something that's got 12 hours left. And that's just because that is the blood that's available. Sometimes you can be poorly disadvantaged by your blood group. So people who are blood group B, the donor population of group B is 0.2% in this country. So very, very small population. And then of the 0.2% of people who are blood group B, only 1% of those people will donate. So as you can imagine, if you're blood group B, it's much, much harder to get blood units for you, which means that those blood units tend to hang around for a lot longer because we try to reserve them for the patients who need them. And then obviously we try to give you the blood that is the same group as yourself because it is better for you, but you can be unfairly disadvantaged. The same also if you are group O neg, because if you're O negative, blood stocks for O neg tend to get tailored towards the use of emergency blood, and also for the use in neonates and our babies. So our babies and neonates, we don't give them group specific units or blood groups that match them. We give them O negative because we need to do additional extensive testing to ensure that that blood is as safe as possible from a reliable donor. So unfortunately, if you're O neg, sometimes you can be disadvantaged by that and you will get slightly older units because the newer units will go towards that sort of testing. And it can be quite difficult. Also, if you are in a hospital where transfusion is not something that is done a lot. So at my hospital, King's College Hospital, we are the biggest single site user of blood in the country. You very rarely get old units because they go into patients as soon as they come through the door. We transfuse about 2,500 units of blood a month at King's. If you work in a hospital where you only transfuse 50 to 100 units, you can imagine some of those units sit on the shelf waiting for somebody to need them for a little bit longer. And that might be sometimes the reason why you get slightly older units of blood. And as you can imagine, for stock management in blood, it makes sense for you to try and get rid of the units that are going to expire so that they don't get wasted. So you want to try and give them to patients so that they don't go in the bin instead. And I know that can sometimes be quite frustrating, but these are the things that we need to take into consideration when we're trying to transfuse patients.